I'd like to welcome back Francesco Pegoraro, who's going to talk on his natural history study of ECD, a preliminary analysis of over 1,000 patients.
Thank you, Matthew. And this is probably not the right title for this presentation because I think that analyzing all this data, we came up with something more than natural history, and of course I have to say immediately that this is still preliminary, and I'm very happy if we can have a discussion on that. And I think quite all of you contributed to this data, and I think this is one additional evidence of what this group and this community can do. So this work starts from many questions. Of course, starts from the complexity and the heterogeneity of the disease. We know that thanks to the ECDGA, the awareness on the disease has improved much, and I think this has improved the diagnosis as well. Over these years, many different shades of the disease have emerged. I think of mixed histio-associated cancer, but also associated autoimmune conditions and many colon hematopoiesis and so on. I think we still had this question, and we discussed with Julien a lot about this. Could be that also in ECD, if we have larger numbers, the prognostic value of the BRAF V600 mutation comes out as it is for children with LCH. And of course, I think the one very important question is to really define the prognostic factors in ECD and to see if those have evolved over the decades. So this is the classical definition of organ involvement in ECD, which was made by the prospective study by the NIH group, and but again here we can question ourselves: has the disease spectrum somehow evolved while our knowledge evolved? Are we better in diagnosing patients? Do we diagnose them earlier? And of course, the question is always, how can we do better? This is an example from a work that that was just accepted, and which is another example of how putting efforts together can give very good results. And this came out of a very large cohort of patients that was collected through the network, and we applied an unsupervised clustering model to see if there were some disease features that cluster together, and we actually find three very strong clusters that this is unsupervised, so it's not us who said this has to go with this. The algorithm did the separation. So, and this recapitulates very well what we see in the clinical practice. So we see patients with multi-system involvement, who have very high frequency of BRAF V600 mutation and widespread disease. We have what we define a limited cluster because the number of involved organs is much lower, and we have a third cluster that recapitulates very well what Jérôme and Julien described and Eli described for MAP2K1 and RDD associated mixed phenotype. So this was made on 670 patients, and since then we increased the number of patients that we could analyze thanks to all of you, and we aimed first to see how we did over the decades and how if we are doing well, to evaluate the disease manifestations that prompted the diagnosis of ECD, and if we are improving in diagnosed patients early, to analyze organ involvement on a much larger series of patients and associated conditions as well. And of course, one of the main question is the predictors of mortality. So as I said, we retrospectively analyzed a very large cohort of patients, and we came up for this preliminary analysis. So the data collection is still ongoing, so I kind reminder. But, and we came up for this analysis with 1,044 patients that came from Europe and the US, and a few patients from Brazil as well. And this was a really, really, I think that this was a great achievement to be able to put all these cases together, because this is how we could answer many questions together. This is nice figures that Francesco made, and I think this can recapitulate very well the evolution of the disease. We have put some milestones, what we consider milestones in the disease history, and you can see that the light blue is the new diagnosis, so how many patients were diagnosed every year. And of course, I think that this reflects improved diagnostic capacity, but in the dark blue, it's how many patients, how many prevalent patients we were following in the same year. And here again, the number is much increasing, and this is probably reflecting improved care. And something quite striking, and there is no one of these milestones seems at least to have a very determinant impact on these. So I think it's many things together that contribute, and this is why we need to keep looking at things and find new way to improve. When we looked at first disease manifestation, as I probably reflects the clinical practice of any of you, bone pain, endocrine manifestations, neurologic symptoms, and skin lesion were the most frequently reported. And if we look at which symptom was associated with much or less diagnostic delay, again, bone pain or retroperitoneal infiltration were more frequently diagnosed earlier, while, for example, diabetes insipidus, or endocrine abnormalities, or skin lesion, they took usually much longer to get to a diagnosis of ECD. And this is quite the same, but divided in decades. But I think this speaks more, because you can see in the lower part that earlier the diagnosis was mostly made on bone pain and bone symptoms and endocrine manifestations, while now we're getting much better to recognize a wider spectrum of the disease, such as cardiac, neurologic, and skin, and other type of more less typical, let's say, involvements. When we then looked at disease involvement, and this is, of course, a modification of what I showed you before. So I think that probably, as I said, the shades of the disease have evolved, and so I think we do find much less bone involvement than we historically thought. So it's around 80% now, while, for example, retroperitoneal and periaortic infiltration remains very important features that we find in our patients. And when we looked at mutations, I think this was very large analysis, and this is quite representative, I think, of the mutations. So it's 60% is BRAF, around 10% is MAP2K1, and then we have KRAS and RAS, much less frequent, and some other BRAF indels or fusions, sorry. And we were also quite happy to see that what we described on a much on a littler cohort with respect to mixed phenotypes was confirmed. It was around 10-15% of patients with mixed histio, mostly ECD-LCH, but also ECD-RD. But also we confirmed the finding on clonal hematopoiesis on more than 500 patients, and the prevalence still remains around 40%. And as I showed you before, also about second cancer, it remains about 25-26%. We then looked at if the type of organ involvement was evolving during decades, and of course the first period which goes before before 2005, it's a bit underrepresented, and this is, of course, we cannot do much about that, but the age is a bit different, so now we diagnose patients a bit older, but there might be some problem about these, as I'm showing you later. What is sure that recently in the last decade we do diagnose patients earlier, and there are, as I said, some feature that we do find less frequently, such as bone and facial orbit or lung involvement. And of course the mutation spectrum has evolved, because recently we do look for more mutation, and so we find more mutations and different mutations. We had a look at first-line treatment only in this analysis, and of course the majority of patients historically were treated with interferon alpha, and more recently with BRAF and MEK inhibitors, and this has of course changed among decades, and I think this is even more striking, because you see that earlier almost half of patients received either steroids or chemotherapy, and then started to receive interferon, and then of course interferon became more important and BRAF inhibitors came, and if we look at the last 10 years, it's half patients do receive inhibitors, but what we discussed with Julien also yesterday is that there is still this proportion of patients which is not irrelevant that still get steroids as first-line treatment. We finally looked at survival, and the overall survival rate was around 80%, and the median follow-up was almost 5 years, and these deaths were now around half of cases clearly related to ECD, so half and half. And when we looked at the probability of survival at 5 years, it was at around 85%, which is still better than what we see in historical cohorts. And then we did look if some again preliminary, but if something was associated with an increased risk of death. For example, we did look at BRAF, and it seems that at least if we get more patients, it's close to significance, but of course there are many confounding factors here. We then looked at how survival had changed over decades, and this was quite surprising at first glimpse, because what we see here, that it seems that older patients do live, were surviving more. But then we did just a simple age and gender adjustment, and the significativity was lost. But then I think the next step was to think about selection bias, because of course those older patients are probably the patient that went well and that were still followed after many years, so that we probably don't have data about patients that went bad or in older times. So we are trying to think with Francesco and how to really take into account this potential selection bias. Finally, we did look at prognostic factor. This is again a preliminary analysis with a univariable analysis, and there are many things that come up. Age, of course, but also some disease-associated features, such as lytic bone lesions that, as we described in the mixed phenotype, mixed ECD-SCH paper, seems to be associated with better survival, neurodegeneration, and multisystem involvement that goes on the heart, the perirenal, the periaortic infiltration. Associated cancers, and as I said, the BRAF V600E mutations and clonal hematopoiesis. But when we do the multivariable analysis, the factors that really get stronger are, of course, age and associated hematologic cancer, but also, and this is, I think, quite a message, neurodegeneration and what neurodegeneration-like phenotype, and elevated CRPA diagnosis, which we can think at as such as inflammatory phenotype of the disease. So to conclude, I think that we can agree that somehow diagnosis and care have improved over the last decades, and this is thanks to all of you. We still have a relevant mortality rates that we have to address and somehow, but I think this is also a bit biased by better recognition of the disease nowadays. We have these features that seem really strongly associated with higher mortality rates, such as older age, associated cancer, neurodegeneration, and this inflammatory phenotype. What can we do now? To conclude a bit this analysis, I think we still need to evaluate better the role of treatments, to look better at other classical, cardiovascular, for example, risk factors, and what Francesco is doing with his ECDGA funded project is to try to develop a comprehensive score, prognostic score that can help us assess the risk for each individual patients. But of course, I think the main message is this cohort has been built thanks to the ECDGA network and thanks to all your efforts. So I think please do consider this data of everyone to be exploited, and so really let's discuss any potential ideas and suggestions to do so. And I think it's all of you, so I'm gonna thank the community for these achievements.